Hello everyone. Now I'll be discussing question on cardiology. So a large clinical trial was done. Patient with recent myocardial infarction and heart failure, and it was randomized to study medication or a placebo. Well, left ventricle ejection fraction of the study subject was around 33%. That means grossly heart failure. Now, both group were concomitantly treated with beta blocker and ACI or ARB. The long-term all-cause mortality was shown in the image below with the solid representing the study medication. In summary, the patient were already taking beta blocker or plus ACI or ARB and the new drug was added and they want to see the effect in a patient who already had an infarction with heart failure. Well, you can see this is definitely survival percentage. This is the drug and this is the usual. So definitely if you can look into the graph, definitely this trial drug has substantially benefited the patient. As you can see, the survivability is much better with this. Now the most likely medication what have been used is eplerenone. Okay, well, but before we discuss what is the mechanism of action of eplerenone, is a very simple. Stop the video, write down the answer. Well, the answer of this drug is very simple. It's a aldosterone receptor antagonist. Its action is almost same as spironolactone. Okay, exactly same. The only advantage of this drug is it causes less gynecomastia. This one advantage of this drug over spironolactone. Well, stop the video. I have got one more question for you. Tell me any drugs which are potassium sparing diuretic just like spironolactone and eplerenone, but they are not aldosterone antagonists. So the question is repeating second time. Potassium sparing diuretic, but they are not dependent on aldosterone. Quickly write down the answer. Answer is triamtrene, amiloride. They are the two drugs which are potassium sparing but not related to aldosterone. Well, so now very important question, very important point. There are many medications that have been shown to improve long-term benefit in left ventricle failure, systolic dysfunction. Especially after myocardial infarction, like in this case. And these drugs which have a mortality benefit are ACEI, that is angiotensin II receptor blocker, what we write as ARBs, beta blocker, what we can write as BB, mineralocortical receptor antagonist, what we write as MRA, and it is this which include spironolactone and eplerenone. A combination of hydralazine and nitrate, especially in black patients. Okay, so African patient like. So in these we have the other drug which are included for the mortality benefit. Now, well, in this the patient taking the study drug, solid line. Now, in both the group, patient is already taking beta blocker and ACEI. So definitely we are left with one drug which is a MRA, which has got definitely mortality benefit. So this must be the option. Now, well, as I told you, spironolactone and eplerenone both are MRA. They block the deleterious effect of aldosterone on the heart. Okay, ultimately they are going to reduce the intravascular volume, plus they have direct action also controlling BP and improving heart failure. They have shown to improve overall survival and hospitalization for heart failure patients, especially symptomatic patients with LV systolic dysfunction. So they have a direct action on the myocardium and as well as a diuretic also. The double advantage, that's why they are benefit for the patient of heart failure, especially after MI. Now MRA, which are mineralocorticoid receptor antagonists, are indicated in certain patients who have persistent heart failure despite use of ACI, ARB and beta blocker, especially when the LV ejection factor is less than 40%, or symptomatic heart failure. In such condition, despite use of ACI in particular, patient still has problem, then we can add these drugs. Now, in the list, I gave you the name of hydralazine and nitrate also, which especially they help in heart failure in black African patient, to be more precise. How do these two drugs, what the mechanism of action to reduce heart failure? Stop the video, write down the answer in your copy. Well, hydralazine is a peripheral vasodilator. So thereby it reduces afterload. And once the afterload is reduced, forward flow is increased. Nitrate, it is a potent venodilator. Thereby it reduces preload. When the preload, that means lung will be decongested. Less amount of blood will be going to lungs. So they reduce the afterload and they reduce the preload, and that's how they are going to benefit heart failure patient. Now regarding amlodipine and calcium channel blocker, okay, these are the two calcium channel blocker, amlodipine and diltiazem, they are calcium channel blocker. They can reduce the BP, but mortality benefit is not seen. Okay, so they are not recommended in LV systolic dysfunction following MI because they don't have any mortality benefit. Similarly, digoxin, when we use, okay, they can have symptomatic improvement. So adjuvant therapy for symptom control in patients with heart failure and LV systolic dysfunction. The advantage of this drug is they simply reduce the hospitalization for heart failure. But as far as there is no mortality benefit is there. Hydrochlorothiazide, which is a type of diuretic, like even furosemide also. Metolazone, they're all diuretic. They don't have a direct mortality benefit. Of course, symptomatic relief is there, but mortality benefit is not there. Mortality benefit is there with MRA. So the golden line to remember, medication shown to improve long-term survival in patients with left ventricular systolic dysfunction. They include beta blocker, ACEI, angiotensin receptor, 2 receptor blocking drug, so-called ARB, mineralocorticoid receptor antagonists like eplerenone and pyronolactone, combination of hydralazine and nitrate, especially in black African patients. Thank you very much.